Our first presenter, Dr. J. Riva-Cambrin. He is a pediatric neurosurgeon at Alberta Children's Hospital. After graduating from medical school in June 1998, Dr. Riva-Cambrin completed his neurosurgery residency at the University of Toronto, Canada. He obtained a Master's of Science in Clinical Epidemiology from the University of Toronto under the direction of Dr. James Drake. Dr. Riva-Cambrin completed a postgraduate fellowship in pediatric neurological surgery at the Hospital for Sick Children, University of Toronto. Dr. Riva-Cambrin's clinical interest is in pediatric neurosurgery, specifically including the treatment of hydrocephalus, craniofacial surgery, endoscopy, and clinical epidemiology. He is the scientific director of the Canadian Pediatric Neurosurgery Study Group. He is also a principal investigator within the Hydrocephalus Clinical Research Network. Recent research interests include comparing the outcomes between endoscopic third ventriculostomy and CPC and shunts in the infant hydrocephalus population, predicting success in ETV and CPC. Treated infants. Sorry, that's a bit of a tongue twister there. And exploring the relationship between ventricle size and neurophysiological outcomes in older children treated for hydrocephalus. He has been a principal investigator or co-investigator on 17 grants and has over 150 peer-reviewed publications, mostly focused on pediatric hydrocephalus. Dr. Riva-Cambrin joined the faculty at the University of Calgary in 2015 from his previous role at the University of Utah. He is a professor of neurosurgery, the residency program director for the neurosurgery training program, the co-educational director of ACHRI, and the largest grant history in Alberta, One Child Every Child. Lastly, he has just been awarded the Kinsman Chair of Pediatric Neurosciences at the Alberta Children's Hospital. Dr. Riva-Cambrin has also recently taken on the role of Chair of Hydrocephalus Canada's Medical Advisory Board. Please welcome Dr. J. Riva-Cambrin today. Thank you.
Hey, thanks a lot. That was really kind, Sean. I'll try to go through this and leave some time for questions, I hope. So I just want to talk. So I'm a member of the Hydrocephalus Clinical Research Network, of which spina bifida is, as you'll see, the second most common cause of pediatric hydrocephalus in North America. And so we do all sorts of studies looking at all sorts of hydrocephalus. And we collaborate through a multi-center approach. And I'm just going to use us as a case study, see why this is so important. No disclosures, and a ton of these studies are not just my studies, but studies of our entire group, of which 14 centers across North America. So collaboration, it's like, oh, well, that's like selling apple pie or like, of course, like, or peace, it's like easy, but it's not. So like the upside is you have more power when you get more groups together, you have more power. Your results matter, generalizability apply to everybody. It's faster to get up numbers, and then you get networks of people. So you become friendships and colleagues, and you can move ideas faster. So what is their downside? Well, it's always money. Collaboration costs more, it's more work, it's slower, and heterogeneity, but we actually see that as a strength. So because collaboration is key, we birthed the HCRN, and it really started in 2007 with a white paper from the NIH saying, okay, enough studies. All these studies are single center, like 50 patients, and we're just not moving the science along fast enough. So we need multi-center collaborative, pooling their data, longitudinal studies, and make studies that actually change practice. But again, it's easy to say, harder to do. So again, this 2007 then birthed the HCRN. So who are we? This is just a thing from our website. So and we are collaboration. So there's a picture from, I don't know, I think this is 2010 in the early days in Park City, of which we're having our meeting next week back in Park City. And this is our last meeting. So you can see the HCRN. These are all people who care about pediatric hydrocephalus from all over North America. And this is only about half of them that are in the network. So 14 sites for Canada, it's Calgary, Vancouver, and Toronto, and 11 American sites at our data centers in Salt Lake City. Yeah, and I can't believe it's 19 years old. The reason and so our mission is to dramatically improve the lives of children suffering from hydrocephalus by conducting important field-changing multi-center research. It was a 5 to 10 year vision, and that's why I can't believe it's been 18. Like we didn't think we'd last that long because it's hard to get funding, but we did it. So, and it's just continuing to accelerate. So what you might say, what is the HCRN studying? We're studying everything, hydrocephalus. So clinical things, neuropsych outcomes, quality of life outcomes, proteomics. What does that mean? We're measuring proteins in the brain, seeing if we can predict IQ 5, 10, 50 years later from certain procedures, which procedure is better than the other. Cost effectiveness is a study. It's hard to get governments to change, but they don't care as much about neuropsych quality. They care about that, but when you present a cost effectiveness study, you really get their attention and you can really change. And then socioeconomics as well. And then we use every tool in the toolbox. So we have prospective studies, which means gathering live data, retrospective, going back and getting some data, randomized control studies, QI studies are studies like usually that we're just looking to improve systems in the hospital. Like the HCRN has a new shunt, well, it's not new by any means, but a shunt protocol. So if you get a shunt at any one of our 14 centers, it should almost be identical, whether it's done here or Birmingham, Alabama. And then AI is a big thing, which we'll talk about. So if you're wondering what are we publishing on? We're publishing on overall burden, proteomics, shunt infection, shunt malfunction, and certainly ETV. So just coming, I don't want to discuss all of 18 years, but just the centering on the collaboration, like what are some things that we've done since the pandemic? So one is I'm the principal investigator of the registry or what we call the core data project. So we finally, it's finally bearing fruit. So I started this in 2006 and when we had 4 centers, and you can see the timeline there, 7 centers, 9 centers, 14 centers. And we built the registry to answer 4 questions, which have been published now. But and then now it's just gone viral. But the hard part, why people don't do registries, everyone talks about doing a registry, but very few do. Number one, funding. Number two is like it takes a long time. It's like planting an apple tree in your backyard. You're not having apple pie next week, or next year. It's going to take like 4 or 5 years before it grows big enough and can bear fruit. And that's you have to sort of be patient. Now we've gotten through that, and now we can tackle all sorts of things, big and small, in pediatric hydrocephalus. So just to give you a flavor, 20,000 procedures plus, and then 9,000 patients in our registry. So with the registry, it's kind of done things like this was talked about, but now this is for sure. Like, what does hydrocephalus in Canada and the United States look like? The number one cause is premature IVH, and that's accelerating with the million new Canadians. Our hospitals are being overrun right now with prematurity and IVH. Especially in Alberta and Ontario. And so myelomeningocele is the second one, less common in Canada, but but um, but building. We're seeing a resurgence of spina bifida in Canada, and it's for good cause. I think people are having more hope with, and that's why we're seeing more pregnancies brought to term. And then you can see all the other causes for hydrocephalus. So we can answer little questions. I don't want to get into like nitty gritty, but like these are some of the recent publications just in the last few months. Just to so we have some kids that are very complicated. So most have one shunt, and even that can be complicated. But you can see here a patient that has basically 3 shunts all wide together, and it's very complicated. And when they come in, it's very difficult to find out. We know a shunt's blocked, but which one? So this is the power of collaboration. So normally people would publish like a 15 patient study on this, and it wouldn't be terribly useful or change practice. But we're able to use 14 centers and find out that Like, should we split them and make two separate shunts or tie them together and make one shunt? And the answer is either works, which is great because people have their biases. And but if you do two separate shunts, it's easier to figure it out, and the surgeries are a little shorter. And there's some other data that shows they might go home a day earlier. So that just came out last month, I think. So sometimes kids can get an infection in their belly and rarely get a pseudocyst. You can see that that's a picture of the belly there, and that's just one giant cyst. And so that's an infection by definition. So again, 14 centers, like it's a relatively rare complication. So people would publish three, four of these, but we can publish 141 and really get out the granular detail. So what's when you have that and you fix the infection, should you put the shunt right back into the belly or should we put it into the heart or the lungs? And the answer is it's a little bit complicated. So you got as with everything, you've got to individual decide individually on the patient. But now we can give the doctors and patients some numbers. So if you're going to plant it back, you don't want to put it back in the belly. That's okay, but the penalty is it's almost twice as likely to fail if you put it back in the heart. But your infection rate is much less if you put it back in the heart. So it's like, it's a bit of a Sophie's choice, but at least it's an educated Sophie's choice. So if you can't put it, I said you can put it in the heart or the lungs. And so again, 14 centers, a 400 patient study. So these are enormous studies for surgical series. And where the best place to put it. So these are things that are complicated because there's a lot of nuance to it. Different centers have preferences, different ages, and you can see putting it in the heart, that's a VA shunt. We're putting them in younger babies, the ones that are premature. The pleura more often are put in older kids who we think the lungs can handle it. It goes around the lungs. And we see it much more common in kids with myelomeningocele. And so what we found was only one significant trend that age under 6 months and VA shunts do significantly worse. So we're going to try, based on this study, try to avoid VA shunts in this case. And what this study already prompted the HCRN to do is push to put these shunts back in the belly, even when the general surgeons say, no, the belly's not ready, but we can push it back into the belly, and we're already seeing this paying dividends. And this study was just published, I forget, like 6 months ago. Yeah, 6 months ago. Okay. Um, so multi-center approach, it's more than just numbers. Yeah, more centers, more patients, more power. But with what can you do with that power? So when you have these mixed populations, you can use it to you can control for that um, and and eliminate some biases, and therefore you're more likely to get the truth from our scientific research. Um, and then are generalizable. The more patients in a study, the more likely it's going to apply to you as an individual patient. Because if it's just a study done in Eastern Europe in only a certain type of demographic, and it's an interesting study, you're like, does it apply to me over on the other side of the world in a different system and everything like that? Okay, we've really started embracing the future. AI, I just saw a study come out yesterday that said what percentage of people are using AI in their daily life? And people had to guess, and everyone guessed 12%, 13%. It's 99%. So just everything you're doing is driven by AI, mostly based on your cell phones, but sometimes your refrigerator, your uh, dishwasher now is running by AI sometimes. Um, so machine learning is driven by data. So when people start talking about machine learning or artificial intelligence, it needs as much data as possible, and the computers love the more and more heterogeneous data. Like the last thing the computers want, and actually scientists and statisticians want, is the same data over and over. You'd learn nothing from that. So like this is an example of how we used it. Previously, I studied like looking at risk factors when you put a new shunt in. What are risk factors for it failing? So if you have to put it in under 6 months, if you have a cardiac comorbidity, and then they use the endoscope. Believe it or not, we showed that the use of endoscope was negative. And so that's been banned across the HCRN. But we wanted some years later
Why
to go
is
back
this
and look at this
important?
exact cohort. And instead of using traditional statistics, we used AI and then we added a few more variables. And the AI that's the old 0.61 is basically the accuracy. So 61% is the old um, way of doing it with statistics. And you can see those are four other a four other computer modelings with it based on AI, and they improved it, but not great. Like what we're looking for in the next few years in the medical world is AI predicting things like above 90 to 95%. Um, and so you can see we're still in the 60s, but this is a very new science. Okay. Um, the other thing is when you use art, when you start reading about medical studies and AI, you'll hear this term black box. And so when I analyze a study, I can say, okay, well, these are the four things driving shunt failure. And so patients can then look at that and say, do I have this, and this? Okay. And then you can see, oh, geez, I am high risk or I'm low risk. But AI doesn't do that. AI just tells you if you're going to get a shunt or not. It doesn't tell you why, and that's why it's called black box. But there's a lot of new computer scientists out there that are working on what we call white box models, which you can see through, and the computer will tell you you are going to get a shunt, and this is why you're at high risk. Okay, so that's a really big concept coming out of the medical literature, and we're on top of it at the HCRN. Um, yeah, I think for time's sake, I'll just skip that study. More to show you that this is old school statistics and all those are AIs. And in this study, old school is still beating AI, but again, in its infancy. Okay, in the last few months, though, some other big the big turn of the HCRN is, I mean, we always studied what's failure, what causes failure, what's causing infection, but more and more, we're just based on what patients care about, and so patient-centered outcomes. So this is an example of the old thing, failure versus no failure, which is a big study. Our randomized control study is it better to put a shunt in the front, in the frontal area, or the posterior area. So you can see two pictures there. Those are the two types of shunts. Those are really basically the only two places you can put the shunt. I mean, you can do it on the other side as well. And so this was our first randomized control study. We were given a couple of $1 million from the Patient-Centered Outcomes Research Institute in the US, which was built by President Obama and still exists now, and is relatively protected from some of the big changes that have happened in the NIH lately. So what we showed here is though it looked like the anterior was better than the posterior. Um, Early on, but that's what actually happened. But we had a special council look at every shunt failure and decide whether it was a really shunt failure, because surgeons can kind of vary a little bit what they think is failing and not. And so when we adjudicated, it wasn't. So and then we tried to look at did one better, did one cause more complications, did the kids go home sooner with one or the other, and that didn't. So basically, anterior and posterior shunts are both acceptable for first-time shunt insertions. So you can read this. This is a negative study because it didn't show one superior than the other, but it also gives patients and doctors some comfort. Like, geez, I always did posterior. Have I been doing patients wrong all these years? My forefathers taught me posterior, and I thought it was safe. And the answer is no, our forefathers did know a little bit that both are acceptable. This is where I did a study along with the Hydrocephalus Association in the US, and just looking at kids that got endoscopic or third ventriculostomies at older age. This with 8 centers, and again, power. You're seeing 14 centers, 8 centers, 12 centers, and looking at kids with big, like, does the size, once you're treated, does the size of my ventricles affect my IQ? And the answer is no. That as long as they're treated, that it doesn't matter what the final resting state of your ventricles are. Now, this is a study only of older age kids, so kids that got ETVs later in life. Um, like after it's school age, after grade 2. So the vast majority of kids get shunts in neonatal. So this only applies to those older kids. But you can see again, what I mean is that these are care like patient. When I see parents and kids in my clinic, they want to know, is my shunt failing? Am I getting an infection? Of course. But the number one thing is my child going to college? Are they going to school? Are are they going to struggle in school? I mean, we're hearing that, and that's why we're pivoting towards these types of outcomes. And here's one fairly right hot off the press from Ohio State, and just looking at preemie IVH again, the most common cause of hydrocephalus in high income countries, and those treated with a temporizing device versus going right to shunt. And we compared those two, and they appeared to be similar in most clinical aspects. Um, but the ones that were treated early on temporarily and then went on to a shunt, so we can kind of controlled it early when they were like only 1 gram, were doing better cognitively at 2.5 years old. There's two types of temporary devices, a reservoir and a subgaleal shunt, but this study also showed that there's no difference. So there's indirect evidence to treat preemie IVH early with any type of temporization device. So this study came out, and this along with some work coming out of the Netherlands and England, showing similar that we have now written up a massive study just to do a randomized control study of early versus late in these kids, and we're just waiting to hear if we get funding. Multidisciplinary collaboration further enhances. So it's not just the HCRN isn't just multi-centered. We have diversity within us. There's basically, I don't want to call them psychologists, but psychometrists who specialize in quality of life. We have health economics and a lot of neuropsychological testing now in the HCRN. So with this collaborative group, what are some ongoing studies that people might be interested? So the ETV CPC is huge. It's a huge part of what I study. So this is a paper that's just about to be published. And so when we look at babies, so babies can either get a shunt or an ETV CPC if they have the correct anatomy. Um, which ones use up more healthcare resources? And so you're thinking, well, we don't care about that. What governments do, and governments are the ones that change laws. And so we need to work on this, Sally. We work on the patient level, the doctor level, but also on the systems level. And this is like a systems level research. And it shows that kids that get ETV CPC get less CTs, more MRIs, come to visit more. Um, and and then um, when we did some further analysis, found that basically the ETV-CPC use up more resources early on for the first 2 years, and then the shunt kids start using more resources after 2, and ETV-CPC stop using resources. So they're two very different journeys through infant hydrocephalus, and so comparing them is tricky. Um, and so that paper's coming out, and then this other one's following it quickly to see is it cost effective, ETV CPC? We know it fails more. Shunt works almost 100% of the time. And then ETV CPC, depending on your reason for hydrocephalus or your etiology, fails somewhere between 50% and 90%, or sorry, succeeds 50% to 90%. So does that higher early failure rate, is it compensated by, if your ETV CPC though does work, eventually you use way less resources and you're out of the ERs, and perhaps they're doing better in society, perhaps. Um, so this is our first look at it, the cost effectiveness, and I won't get into the nitty gritty of cost effectiveness studies. They're complicated. But it shows that number 38,000 per quality of life year. Anything under 50 is considered very cost effective. And so early use of ETV CPC is cost effective. So This data has just recently been analyzed, and so this is really hot off the presses. So we are going to use that new randomized control study, which I'll talk about in a second, and repopulate our model with the new data and redo this study in 3 years when the trial is over. And the governments and the health systems are all waiting for this data. So again, so how can like this is you're like, oh, health economics is so boring. And it's not. And it's used constantly. Like this type of modeling is used by every government in the world, every military to say, should I put more tanks over here or more missiles over here? It's used by your grocery store. Should I put more jars of peanut butter on the shelves? Or, they model it to see what's more cost effective. So everyone's doing this. So medicine's slow to the uptake, but we're not anymore. So this is just one example of the power of this. So we know that taking all comers, all infants, the ETV CPC failure rate in North America is like 0.5, so 60%. If you take all comers, like you don't try to pick the best people. But ETV-CPC works very, very well for myelomeningocele patients, infants. A very conservative success rate is 65%. So there you can see a 35% failure rate. At 35% failure rate, the green line is the shunt and the blue line is ETV-CPC. You can see a massive difference. And so the conclusion of this study is, especially for kids with spina bifida and infants, ETV-CPC is very cost effective. But again, we care more about who it's fine to be cost effective, but which kids are doing better cognitively at 6 years is more important. And that's the next study. So this is our big study. This is a $10 million trial that we're doing a randomized control of ETV-CPC versus shunt. So if you come to any of those 14 centers, or there's 5 others participating, we will, and you need to shunt or an ETV-CPC, we'll ask, you can have one or the other, or we'd say, would you like to help science and help the children of the future? Join the study. The parents have to let go a little bit of control because they have to consent for both studies and then let it be randomized. So let a computer decide which treatment your child gets to eliminate all parental, physician, nursing biases. And so that's going on. The study is about to close in 6 months. And then we got to wait and watch these kids for another two years to do all these testing. And then you're going to see a big publication come out. So multi-centered clinical research is the only way forward in mind. Yes, it's more work, complicated, expensive, but it allows burdens to be spread across centers and brings to people with lots of different experiences together, which most importantly gets us closer to discovering truth and really making an impact on the lives of children with pediatric hydrocephalus, which is right back to the beginning of our mission. Great. Thank you.
Thank you so much, Dr. Riva-Cambrin. That was very interesting. So many different research projects happening in the HCRN. I was looking to see if there was any questions, and I don't see any from the community, but I had one.
Sure.
How do you determine who gets a shunt and who gets ETV?
Well, so ETV, if you're older, like in the past, you would never do an ETV under the age of 2, but the ETV CPC changed that. So now that if you get it under the age of 2, you should probably have the choroid plexus cauterization. Any kids though, the one things you look at is basically the anatomy on the MRI. So you have to have the easiest way to answer the question is to have obstructive hydrocephalus. There has to be a clog in the pipeline at some point because an ETV is just a bypass. A shunt will treat all types of hydrocephalus. Okay, ETV mostly just treats obstructive, which is about 60% of hydrocephalus, but not all. And so that's what we do. And then if you're under 2, the same decision, but you have to add the CPC.
Thank you. One other question I had was, what is the different symptoms of failure between ETV and shunt? Or are they the same?
They are the same. Yeah. This is a big thing because we treat a lot. Like I just got back from Europe from a hydrocephalus meeting, an endoscopy meeting, and it's funny, the Europeans treat ETV like a cure. And we never have, and we never will. Every time I do the ETV or ETV CPC and it's successful, I tell parents to make sure you get a medical alert bracelet or whatever. Like make sure you educate your child when they're older that it's like diabetes. You have a chronic disease. It's under total control right now, but it can get out of control, you know? And so using the cure word is very, yeah, we do not like it. And so that's why they don't follow you. They just treat you and say, oh, you're done. Bye. You know, we follow you, all of us in North America, Canada, and the US. Um, so anyway, your answer was how do they present differently? No, they both present the same headaches, vomiting, sleepiness, drowsiness, blurry vision, poor vision, or sometimes more subtly poor school performance and stuff like that. That's rare. Um, yeah, but we do have some very rare delayed failures of ETV, but they do happen.
Okay. Thank you so much for your presentation. And I know that you have a busy day today because you're on call, so we'll let you go.
Okay.
And we'll move into the next presentation. But thank you again so much for joining us this morning.
Yeah, thank you. And congratulations to all those award winners. Gamble, too bad he wasn't on there. He was my patient for many years, and now he's in
Oh,
university. So I'm so proud to hear that he won that award. So anyway,
wonderful. Yes,
I'll have to email the family. Like,
he's received the award 2 years in a row now. So
oh, wow.
he's really working towards his degree.
Okay. Well, congratulations to all the winners. So,
Thank you.
okay.